Hi, and welcome to the Mini Battle C series by Athens Shoulder Course in partnership with BMed. My name is Manos Brilakis, and I am the head of the organizing committee of this course, being driven by our passion for continuous education, development and communication with our international friends. We came up with this idea of launching monthly webinars dedicated to shoulder pathology and treatment, the Mini Battles E-Series. Counting down to the next Athens Shoulder Course, we hope to welcome you and host you again live in person in Athens next May.
Hello from me also. I'm Manos Antonogiannakis. I am the chairman of the Athens Shoulder Course. And unfortunately, due to the COVID situation, we had to postpone the 5th Athens Shoulder Course that was to take place in February of 21. And Manos and me thought, okay, how we are going to be in contact till the next Athens Shoulder Course? And we decided to have these discussions. And so every month we have a topic to discuss. We try to invite our friends, very good surgeons, exquisite shoulder surgeons, and have a discussion about an interesting topic. And today we are going to discuss about the tenodesis of biceps. Why do we do it? When we do it? How we do it? Where to do it?
But before introducing our guest, please take a moment to vote our first question, which is when we manage a small or a medium rotator cuff TR, what do you prefer to do with the long head of biceps? Do you preserve it? Do you do tenotomy? Or you do tenodesis? Take your time and answer.
So tonight we have four surgeons and shoulder surgeons and friends. And let's start with Mrs. Maristella Saccomanno. She's a very good friend of ours. All of these surgeons are ESA partners, and Maristella is going to, from Brescia, and she is going to present us the suprapectoral tenodesis as a better option for managing the biceps. And also, we have with us Dr. Med Felix Dyrna. He is from Münster. We have many discussions with Felix. He is one of our best friends, always interested in scientific shoulder problems. And he is going to discuss about his preferred subpectoral tenodesis of the biceps, open subpectoral tenodesis. Also, today is with us is Professor Knut Beitzel and Knut from Cologne. He is going to share with us the discussion about the tenodesis of the biceps. And we are going to have a lot to discuss, as this problem is a problem that we face every day. And last but not least is with us Professor Pericles Papadopoulos. Pericles is well known for his interest in shoulder surgery in Greece, and not only in Greece. And he is going to share with us his experience in the tenodesis of biceps.
Thank you.
So welcome all of you in the mini battles. In the episode 9, throughout the mini battle, please, you can submit your question and your comments. And with no further delay, let the mini battle begin.
Good evening, everybody. I'd like to thank you, Manos and Manos, for inviting me tonight
so I have no conflict of interest for this presentation. I'm sorry, I don't know why it's going so fast. So since this is a battle, I decided to start in a provocative way. So my first point is, why not always arthroscopic? We all know that by arthroscopy, we can make a correct diagnosis, we can really see the pathology, address stability, and of course, just perform the best treatments. And when it comes to surgical treatment of biceps, main options are surely biceps tenodesis or tenotomy. I would not say that tenotomy is not part of my clinical practice anymore. Tonight we're going to focus on the tenodesis. What we can say, we say that literature just showed that there are no significant differences in functional outcome between tenotomy or tenodesis, but tenodesis has the main advantage to lower the risk of Popeye deformity and postoperative cramping. So what are my indications for biceps tenodesis for arthroscopic suprapectoral biceps tenodesis? Of course, symptomatic patients. Most of the time, it is not an isolated biceps pathology, but of course associated with a rotator cuff lesion. Usually, I prefer tenodesis in younger patients with an high functional demand. And of course, on the other side, I use biceps tenodesis as an option in case of revision / repair. Let's have a look to what are trends in the United States in the last 10 years. This is a very recent paper that just showed that in the last 10 years, tenotomy went down and tenodesis increased on both sides, open, supac, or arthroscopic suprapac biceps tenodesis. But since this is a battle between open and arthroscopic, just try to look deeper into this data and look at the to another recent paper, 8,547 long head of the biceps tenodesis were observed, and what was noticed that open tenodesis is usually the best choice when you have to treat an isolated biceps pathology, but when it comes in association with the rotator cuff repair, arthroscopic suprapac is probably the better option or the preferred option, at least by US surgeon. And when we talk about arthroscopic biceps tenodesis, we need to have clear in mind that basically there are different location and fixation type. So for location, it can be performed high at the entrance of the bicipital groove or within the bicipital groove, or low just above the pec major at the inferior extent of the bicipital groove. And this is what we usually call the suprapac arthroscopic biceps tenodesis. On the other hand, it can also possible to fix the biceps to soft tissue, so to rotator interval, or even incorporating in rotator cuff repair. But tonight, we will focus on suprapac arthroscopic biceps tenodesis. As I said, different fixation constructs are available, so interference screw, suture anchors, knotted or knotless, or even button constructs. I'm going to show what's my way to do it. As I said, my best option is a suprapac arthroscopically. As you can see, I had a quite degenerated tendon, and it also was subluxated. I usually perform 2 lasso loop on the lateral half and on the anterior half of the biceps tendon by using a direct suture passer, as you can see, quite easy from my lateral portal. Then I retrieve all the suture from the same portal, and now, just now, I cut my biceps because I already chose the length of my tenodesis. After that, I usually use a PIC knotless anchor, as you can see in the picture. This is surely my favorite technique, must because this gives me the opportunity to be sure to restore a current length and tension of the bicep tendon. As we can see in a few seconds, this is surely one of the main issues when it comes to performing a tenodesis. This is the anchor coming down. And that's the final results of my tenodesis, and then I'll go to repair the subscap and the posterior cuff. So why or when to perform an arthroscopic suprapack? Well, we're going to see three main chapters: biomechanics, functional outcomes, and complication. Let's start with biomechanics. Length-tension relationship. Just a second ago, we were talking about this. This is a critical point in preserving muscle strength and efficiency of the biceps tendon. And there are two main issues to be considered. First, anatomic landmark. In this paper, Dyrna in 2012 just showed that probably fixing the tendon high in the bicipital groove is the best way to restore or to preserve the length-tension relationship. Second, the shoulder position. This is a very recent biomechanical studies that show that shoulder extension as well as flexion can influence the excursion of the long head of the biceps, which is approximately 24 millimeter normally. So what's the best position to get your shoulder when you perform a biceps tenodesis? It seems to be 0 degree of forward flexion and 0 degree of of abduction, which means kind of neutral shoulder position. And of course, can be done easily arthroscopically because you can move your arm. And let's look deeper into biomechanical characteristics. So when we talk about load to failure, displacement, or stiffness of the construct we use, this is a recent systematic review and meta-analysis comparing not only suprapack tenodesis versus subpack tenodesis, but also fixation device. So substantially interference screw versus all other alternative, cortical button, suture anchor, all soft tissue technique. And they get that basically there are no differences in any of the biomechanical characteristics considered. One of the main issues that we'll say in the next presentation is probably that when you perform an arthroscopic suprapack, you can have a residual groove pain. Is it true? According to this study, this is not true, because when you perform a suprapack tenodesis, the motion of the biceps tendon within the bicipital groove is essentially eliminated, cancelled. So as you can see in these two graphs, basically the biceps doesn't move. Let's go forward to functional outcome. This is the first and only one randomized clinical trial available right now. It was conducted on 75 patients, 37 treated by arthroscopic suprapack and 38 treated by open subpack tenodesis. By the end of the day, they show no significant differences, not in functional outcome, nor in strength or anterior shoulder pain. So as biomechanical studies show, residual groove pain is not an issue even when you perform an arthroscopic suprapack. Data that could be considered controversial, that the study I just showed you, and another recent study, they just say that probably you get much more surgical time for arthroscopic suprapack rather than open subpack. Let me say I respectively disagree. I work with a group of Romeo, and they are very, very skilled surgeons, and probably this is matter of surgeon experience and preference rather than a real issue between arthroscopy or open tenodesis. So keep going with functional outcome. Let's see another meta-analysis. The 7 comparative studies were included. As you can see, when we talk about suprapectoral, mainly fixation of the biceps into the proximal or distal to the biceps group were included. Of course, not only isolated procedures were considered, but mainly concomitant procedures. So suprapack and subpack tenodesis were compared, and what we get that from for the constant score, there were no differences between the two groups. We got some statistical significant difference for the ASA score, but it does not reach a minimal clinical important difference. And most important, there were no difference in VAS score or even direct consideration of bicipital pain. But pay attention, because when you compare, when you read meta-analysis, you need to pay attention to methodological issues of included studies. And usually meta-analysis for comparative studies is the best way. Plus, when we talk about functional outcome, they're not specific for biceps. And as we said before, concomitant procedures are usually performed. So probably we should put our attention when we talk about biceps tenodesis to pain scores. And I'd like to cite this, this paper because I think it's at a point right now. Now some cutoff values, some new threshold are gaining popularity when comparing studies and procedures. So this group just postulate what's the real minimal clinical important difference, substantial clinical benefit, and patient's acceptable symptomatic state in case of biceps tenodesis for the main score we usually use. So this is a suggestion for future studies, basically. And now let's move to complications. It's nice to say that looking to rate of complication over time, there are no significantly change over time. So percentages are always the same. This means that whatever you perform an open SIP pack or an arthroscopic supra pack, they are very reliable in this procedure. Anyhow, although low, higher rates of complication have been reported in open SIP pack tenodesis. They are very few, less than 2%, and sometimes, and most of them are early complication. Let's see where they are. So why I do not like to perform an open SIP pack in any case, because there is an increased risk of proximal humeral fracture, because wound infection have been reported, and because transient nerve injuries have been also reported, usually resolved in 3 months, but you don't have this kind of risk when you perform an arthroscopic SIP pack. Finally, talking about revisions, it looks like that revisions rate are almost the same between arthroscopic and open supra or SIP pack tenodesis. What is funny, it looks like the male sex is a risk factor for failure of open SIP pack. On the contrary, age over 45 years and rotator cuff tears, concomitant rotator cuff tears, are kind of protective factors for arthroscopic biceps tenodesis. In conclusion, when or why I prefer always to perform an arthroscopic SIP pack tenodesis. This is surely my choice when I have to perform associated procedures such as rotator cuff repair. I think that we have biomechanical and clinical proof that this is a good technique to preserve or restore the lung-tension relationship. Plus, I do not have any issue about surgical site morbidity, at least in my hands, but once again, this is matter of surgeon experience. At least in my hand, I guess it is an easier and faster procedure. Thank you for your attention.
For this very interesting presentation. You were very well prepared for the battle, as everyone saw. Let's move on with Felix lecture.
So, thank you, Manos and Manos. I'm very thankful for your kind invite. I think this is a great idea from you guys. Your course is already worldwide known, and this is even another aspect of making it even more unique. So I'm really thankful for this opportunity. Of course, I do not have anything to disclose, which is really nice for this talk, because now we can talk without any political conflicts. I figured that Maristella would put a lot of work in indications and also, look into all the recent literature. So I figured I'll do a little different way, and I just gonna tell you a more personal way of why I do things the way I do them. Just because there's this really great article from Eric Homan that actually states that whatever we do right now for the biceps, there's really no right or wrong, and everything is about a personal preference and personal benefits. So what you think that you can do good is probably also the best for your patients. And I just collected 5 arguments, or let's say 5 personal arguments that I just want to show and share with you, and hopefully later discuss with you why I like to do the open subpectoral tenodesis. And one of my first arguments is backed up by a really great review article from the Netherlands, and I can really encourage everybody that likes to read something really good. It's a recent anatomical consideration that really combines all the knowledge we have right now. And one structure that is, for me, that makes sense, that I really want to take care of that, is that there's an anatomic bottleneck. So there's a narrow zone in between the groove. Maristella just showed you this region 1, 2, and 3 that is already described by Taylor. And in that region number 2, and that's exactly where the suprapectoral tenodesis will be placed, there we have the transverse ligament. And this ligament is different in every patient, and it can be an issue because of the chronic thickening of the biceps, and that may result into that chronic inflamed situation that causes anterior shoulder pain. So now you have 2 reasons. So when you do a suprapectoral tenodesis, it is recommended to actually cut that ligament. But really close relation to that ligament are some branches from the anterior circumflex artery. So you got to be really careful, otherwise you start a bleeding over there. And the other way is you do the way that I prefer. You just pull the biceps out of this region, you take it out from the transverse ligament, and you put it subpectoral. So first argument for me is that anatomical narrowing of the bicipital groove. So reason number 2, and I think this is also one reason that has been discussed in the literature, but really has not been backed up with a lot of evidence. We do know from histological point of view that the biceps tendon has a different or a non-homogeneous distribution of nerve fiber endings. And we do know that those nerve fiber endings are the main reason for pain generation. And they actually are mostly contributed right at the exit of the bicipital groove. So, and when you don't take out a whole lot of the tendon that stays whether in the joint or just suprapectoral, you may even leave those nerve endings within the body, and they may cause pain. And I know, because Maristella just showed you this nicely, that there is, when you look in larger population groups, it's not significant. But whenever you have that one patient or the 2 patients that come back with anterior shoulder pain, you start thinking, what could be the reason for that? And I also had a couple of those after intra-articular tenodesis, and I revised them with a subpectoral, and they felt better. So I don't know the reason for that, but this is something that I consider when I'm talking about and arguing why open subpectoral tenodesis is the way that I do it. There's one aspect that I think that is really important to mention. So when we talk about, especially when I talk about subpectoral tenodesis, I'm not talking about I'm just doing an open subpectoral tenodesis without anything else. So I always do an arthroscopy and whatever other treatment is necessary, but I always do an arthroscopic tenotomy of the tendon. So I really want to see the tendon first. Like Maristella just showed you, that's actually indication for me to do a tenodesis or a tenotomy. So first I look in, and then I decide if I cut it. For me, timing, and especially when you start out and you're a young surgeon, it's not all about being an advanced arthroscopic surgeon. It's more like every minute you have generated water pressure inside the joint is a minute that generates pain afterwards. So especially if you're interested in doing a lot of outpatient clinic, I really think that the minute you can cut down on arthroscopic fluid inside the joint is also a really great aspect of reducing post-operative pain. So for me, just cutting it and then rather do it later on with my open approach, that really takes down time from my overall procedure. My reason number 4, and this is also a reason that I think it's really important, especially like for me, is the indication when I do biceps tenotomy in cuff tiers. I really have a problem of space. So especially when I have an anterior superior cuff tier involving subscapularis and supraspinatus, I really have an issue in putting an anchor somewhere intra-articular that does not conflict my anchor position of the subscap or the supraspinatus. Because I really like to extend my subscapularis repair over the bicipital groove, I really have a problem with space in that area. And another big thing for me is visualization in an arthroscopic procedure. And you can see here on the right side, this is a typical picture that I do not want to see, the top one, that it's blurry, I have some blood in there. And whenever I put a hole inside a joint that I cannot really good cover, and I do have the feeling, especially when you drill into the bicipital groove, oftentimes you get some leakage alongside of the tendon that might, not always, but just sometimes may cause your vision to be not as good. And that's actually a bad start when you have to do a cuff repair right afterwards. Reason number 5, and maybe the last argument I can bring up here, is something we actually know from other regions, is that whenever we drill intra-articular, and that doesn't matter if it's on the glenoid side or if it's on the humeral side with anchor position, or even from the ACL, we know that every intra-articular drilling has a chance to create cyst due to synovial infusion. It's not always the case, but if you get those big cysts, they also may be a problem in the future. So those are my 5 considerations why I do think the subpectoral biceps tenodesis and open subpectoral biceps tenodesis may be beneficial. There are also some downsides of this tenodesis, but you already heard them from Maristella, so I'm not gonna put too much time into that. I just want to show you a quick video on how I actually do the procedure. I mark the border of the subpectoralis, then I do a small skin incision. Then I take my index finger and I really stay lateral and try to get out that biceps tendon. And then I actually have 2 different options. The video will play twice so you can watch it nice and easily. So in the majority of the cases, I use an old suture anchor from Matrix. Now the bigger one, the 2.0 one with loaded with suture tapes, because I started with the smaller one, the 1.6 one, and I had a couple failures due to suture ruptures on the drill hole side. And as you already saw from Maristella, that there's an issue sometimes with the male and especially young male patient. I really want to have something that is a little stronger than that suture anchor. So in that cases, I use a monocortical endo button. This way I'm able to actually put the tendon a little more into the hole, and I feel I have a stronger fixation, and I use a 5/0 fiber wire for that. So I've never had any issue on rupturing when using that technique. I do not think that there's still an issue. Well, you can see on the upper hand where I just put in that flip button, monocortical. You just put it in nicely, it flips, stays right there, and it's a really strong fixation. And I do not think that we still have any issue with proximal humerus fractures. By now, we drill with, for the soft anchor, a 2.0 hole, and for whatever cortical button you use, somewhere between 3 and the 4 millimeter hole, depending on the implant that you use. And we are far smaller now than 7 or 8 millimeter interference screw that actually cause those torque-related fractures. So I don't think that is really an issue anymore. So for me, there's 3 things that I really think subpectoral tenodesis is the way to go. For me, first, it's simple. I cut it, I fix it later on whenever I have time for it. I can really relax. I have my cuff done, and so I really can focus on what's left then. It's fast. I don't waste time during my arthroscopy. I just leave it and then do it in the end. And it's safe. I have good cosmetics and a strong fixation. But I do have one more slide that I want to share with you, and especially to heat up this whole discussion part, because I really think we still don't know really enough about biceps function, and especially not in the setting of rotator cuff tears, because we were told, or I was at least told, that biceps is always related to pain, and you got to cut it, otherwise you will end up with the later anterior shoulder pain. You got to revise patients. So this is a patient I really want to show you from my clinic. It's actually just 3 weeks ago. So on the left side, you see an X-ray by that patient. You have a center joint with, beginning osteoarthritis, a little bit sclerosis zone, and then he has a really interesting MRI, and that was the reason why he presented in my clinic. So I'm going to show you those two. They're just going to run quick one time, and then I'm going to show you where to focus on. So I really like you to focus on the axial scan. Right here, you see a subluxed or even luxed biceps. That biceps tendon is probably 3 or 4 times as wide as it was before. It's now not round anymore. It's flat. And when you look at, I'm going to pause that video and like on a specific slide. So right here, so now you can see this biceps tendon went actually to the anterior aspect of the shoulder and works now as an anterior superior stabilizer. You can see it really nice. And that guy has no cuff. So when you look one more time for the cuff, there is no supra, there is no infra, there's not much left. And when you see this MRI, just the MRI, I would really know what you think about how his function is. Probably everybody would agree that most likely he will not have a very good function. And I got a video right here. That's the guy, 54-year-old. And that's his function with that MRI. And it's what is really interesting. When I'll go back one more time, you got to look on his right hand. That's the side that is an issue. That whenever he raises his hand up, he squeezes his fingers like he makes a fist. And that way he actually contracts his biceps, and that prevents the humeral head from an anterior superior escape. So I would be really interested what would be happening if I would just cut the biceps on that guy. Doesn't matter if you do a tenodesis afterwards, I'm pretty sure his shoulder function will go down. So this is something to consider, and I'm really interested about that discussion that we may have right now. And I'm really thank you for your attendance.
Thank you, Felix, for this very nice presentation and all these thoughts, and especially for the last case. And now we can proceed with the discussion and see if, Manos, if there are any questions.
First of all, we can see the results of the first poll. Can we have it on screen? So 50% preserved the biceps and 50% made tenotomy. So the discussion for today probably is over before starting. However, we can see our second poll question, which is your usual location for biceps tenodesis? Intra-articularly in the entry of the groove, supra-pectoral working in the subacromial space, or open subpectoral, or do you have some other option? So thanks again for voting, and we can move on with the discussion and invite Knut and Pericles to share their experience. Before now the second round. So I would like to ask every one of you, the biceps, now we discuss the biceps for many options. We can use it in instability. We can use it in the irreparable calf tears for capsule reconstruction, for superior capsule reconstruction. So I wonder if these options can affect your vision for the management of the biceps when you have a small or a medium rotator cuff tear.
So, Knut, what is your thoughts about the biceps and as a pain generator when you have a rotator cuff tear? How you manage the biceps?
I truly believe that the biceps is a big pain generator. And there's very rare shoulders where I do arthroscopy where I don't cut the biceps, either tenotomy or tenodesis. Although what Manos said is a thought which comes more and more to my mind, that perhaps we can save the biceps for later procedures where we can use it when it's still in the joint. On the other hand, while I was thinking the last months about this and getting more and more to be conservative and perhaps not cut every biceps I see, and within the last few weeks, I had exactly 2 patients coming in there, and they had rotator cuff repairs, and the biceps was still in there, and they had this anterior pain. And I really today saw a patient, she had half a year afterwards this anterior pain, she had a rotator cuff repair elsewhere, and then she played golf, and she had a spontaneous rupture of her biceps with a Popeye sign, 70-year-old lady. And since then, she had no pain. And I had the MRI of her shoulder before where they said, oh, we have to do the rotator cuff again, something like that. But it was the biceps. And then she had a spontaneous rupture and she has no pain anymore. So I really believe that this biceps is a pain generator, and perhaps to pick up the case Felix presented in the end. When I switched from the university to private practice, I saw a lot of guys coming with these cuff arthropathies, doing full range of motion. Well, I'm fine. I don't want to have a reverse prosthesis. I want something else. And since 3 months, I have pain. And then you go in there and you cut this biceps, and I try to do some nerve release, okay, but I cut this biceps and I really had a bad feeling in my stomach. And I looked the literature, and there's very good data from Bolo and Walsh's group where they have really high numbers of non-repairable rotator cuffs where they did cut the biceps, and these patients did not experience problems. And that's what I experienced in this group of patients as well. Although I thought, well, the biceps is the only thing still working in this shoulder, and I cut it, and they get rid of their pain and they still keep their function. It's fantastic. I don't know why it is, but it's mostly in my experience this way. I had no patient in my experience who lost his function in this cuff arthropathy because I cut the biceps.
And this is something that happened to me also. First, there are many patients that the main pain is an anterior pain, and this pain goes away if they have a traumatic tenotomy of the biceps. There were patients that I had in the list for operation, and they had to wait, and they came after an incident of acute anterior pain, then a hematoma in the anterior part of the arm, then a Popeye deformity, and then the pain was off. And now we know that this is a major pain generator. And when I was doing mini open rotator cuff repairs back before 2000, we usually didn't do anything to the biceps when we had small tears, medium-sized tears, because we could not see the biceps. And still many of those patients were doing fine. When we started doing it arthroscopic, one of the first things that I noticed was that usually when we had the rotator cuff tear, a medium-sized rotator cuff tear or a small rotator cuff tear, there was a lot of the inflammation in the interval and around the biceps tendon. And I started cutting or tenodizing the biceps, and till then I do it practically always. When I had the rotator cuff repair, I'm thinking also that I have to do something with the biceps, even if the biceps is not inflamed or doesn't have signs of rupture. Then some months ago, 1 year ago, started with all this discussion about ACR with biceps and the use of the biceps for the ACR to think again why not to do why not to leave the biceps for later if we have a failure or why not to incorporate the biceps even to a medium-sized tear. And then again, I had some patients that they had anterior pain and I had to revise them. And so now I'm very frightened again of leaving the biceps because I had never a revision for or the problem was that when I started leaving the biceps, I had again patients that they had anterior pain after the repair and I had to revise the biceps. And now, although I'm thinking to use the biceps in massive cuff tears as tissue there, that collagen tissue or as ACR, I think that in medium-sized tears or small tears, when the rotator cuff is still functioning, the biceps probably is a pain generator. Sometimes I think it's the main pain generator that brings the patient to us.
Yep.
So, Pericles, Dr. Papadopoulos, what do you prefer to do with biceps?
Right. First of all, Maristella and Felix gave excellent talks. And I mean, this is a fascinating topic because there are no papers supporting entirely the one way or the other. I do a lot of tenotomies. When I see that the biceps tendon is not in good condition. And I do a lot of tenotomies because, just tenotomies, because, I mean, the pool of my patients are elderly patients mainly. What I think in labors, in heavy labors, and in some ladies which are very delicate ladies, I do an arthroscopic tenodesis, as Maristella showed, exactly as Maristella did. And because, as Bob Nevaiser said some years ago, that we don't see 50% of the tendon, and although we pull the tendon using the blunt obturator to see if we can see the whole tendon, but we can't see the entire length of the tendon. So I think it's a pain generator, as Felix showed. There's a paper by Alpantaki, one of our compatriots, very good paper. And I do, in some athletes, I don't do many athletes, but I do some tennis player and I do some wrestlers. In those circumstances, I do subpectoral tenodesis, open subpectoral tenodesis. And the reason I'm doing that is that I don't want to have any pain. I use a anchor as well, as I think Andreas Voss showed, or Felix. It's a similar situation. I don't do a biceps tenodesis using a screw because there are reports in the literature that there are fractures, some fractures in that area. So that's my feeling when I'm addressing a biceps tendon.
Perfect. Felix, can I ask you something?
Felix wanted to add something.
Do you have some trick in order to share with us for maintaining the normal length tension as Maristella described when you do the subpectoral open tenodesis? Please unmute your mic.
Oh, sorry. So I think there's some really interesting aspect that is often not mentioned. So usually there was that distance of 2 centimeters from the muscular tendinous junction that was used as a measurement. But those measurements come from a time when people used interference screws. So you use a whole lot of length of the biceps tendon inside the bone. And by now, I actually go shorter. I'm staying 1 centimeter from the muscular tendinous junction and put that underneath the subpectoral tendon, a subpec tendon. And I think that is, for me, that works a lot better because sometimes I ended up before I changed the technique that is a little loose. Not that you see it in clinic, but you don't have that feeling after the surgery that it has the same, tension before and after you actually pulled it out of the groove. So I shortened the way I refixed the biceps tendon. But I just want to add one thing, for the discussion part, that our indication for biceps is mainly a vision or a feeling when we see the biceps that it does not look good. There's a really nice article by Paul Sessi analyzing when he thinks it looks bad from a histological point of view. And there's absolutely no correlation between what we see the biceps look like and how much actually degenerative changes are in that tendon. So looking at that biceps may not be the best way of deciding if we need a tenotomy or tenodesis, but what definitely is probably one thing to consider is its stability. So as soon as the pulley system, doesn't matter if it's the medial side or the lateral side, I don't think when the biceps tendon is unstable that there's a need to preserve it. So whenever you have, upper 2/3 subscapularis tendon, or you have a pasta lesion involving the anterior aspect of the supraspinatus within the SGHL, then I do think that there will be residual pain from the biceps tendon if you leave it.
Yeah.
Okay, Knut, you want to add something? I see it in your face.
Yeah, I just wanted to add, I don't decide intraoperatively if I do it. I try to decide this before I go into surgery. And even what I do with the biceps, I don't like it to decide intraoperatively. So for me, the clinical examination, basically the pain in the groove with the speed test, pain when you go into external rotation. And Maristella also, I think last time when we talked about it, showed this nice pull in the back test, and patients say they cannot close their bra. These are indications for me that I have the biceps on the line. I even cut it sometimes if it does not look that bad, actually. That's more often the problem, where I feel, oh, it looks pretty good, but I rely on my clinical examination in this point.
Can I ask you something, all of you? When you do perform a tenotomy, a surgical tenotomy, how often do you have a Popeye deformity in your practice? I mean, in my experience, it's very rare to have a Popeye deformity after a surgical tenotomy. It's very often when the tendon breaks after a traumatic event, but then the biceps is usually contracting, and this produces the force to drive the tendon very low in order to have a real Popeye deformity. I have seen Popeye deformity after tenotomy only in bodybuilders. I have never seen it in the population. I don't do many tenotomies because for me it's very easy to do an intra-articular tenodesis of the biceps in the entry of the groove. And if I don't have a lot of pain in the groove, that is a clinical examination before the operation, I usually do a tenodesis in the entry of the groove if the patient is not is below 60. But when I do a tenotomy, I have done many tenotomies. I don't remember to have any Popeye deformity. Do you remember?
I used to have Popeye signs when we had in addition a subscapularis tear. So whenever I have now subscapularis tear, although I never do tenotomy, even in elderly patients, I always do a tenodesis in such cases. Whenever we had Popeye sign, we always had subscapularis there.
Yeah. I see it pretty often in one type of patients, and this is this 70-year-old athletic male patients with a massive rotator cuff tear, traumatic. In these patients, I don't want to spend time on the biceps tenodesis, so I just do a tenotomy. And these guys basically most often have a Popeye sign. And I think that's what Pericles says, is because the subscap is also affected in these patients. They don't have a problem, but these little bit athletic guys, you see really the Popeye, and I have it often in these cases.
I actually use a couple of tricks to avoid Popeye sign when I do the tenotomy. First, I cut the biceps at the very beginning, so it's wider. And of course, I don't do anything to the transverse ligament. So it's a kind of new tenodesis, basically, because the biceps is wider and is blocked by the transverse ligament. And then, in order to avoid a retraction of the biceps immediately, I just remove the weights when I perform my tenotomy. So usually it doesn't move. And then I keep my patients in flexion for at least 3 weeks. So usually I don't have any kind of Popeye sign in any kind of patients.
Maristella, there are special groups of patients that makes you to change your strategy and do a subpectoral tenodesis?
No, not for sure. Actually, I mean, I saw a lot of the open subpack. As I said in my presentation, I spent some time with Romeo's group, and they every time they perform an open subpack. But for me, really, I cannot see any advantages. Really, main issue could be a residual groove pain. But in my experience, I didn't have any kind of that, so I can see the reason to change my practice.
Yes, Knut.
I want Maristella. I want to pick up one argument Felix said, and this gets for me more and more important. I work very often with double row repairs, and my impression was that when I use double row speed bridge repairs, I have 4.75 anchor in this humeral head. If I then add another standard anchor into the head, I have 5 anchors, and if you do something to the subscap, you end up with 6 anchors. More and more, I get this feeling, oh man, that's a lot of stuff in these humeral heads. And I'm trying to reduce my amount of anchors. And I'm trying to switching to all suture anchors for the rotator cuff repair, also out of this thought. So for me, having one additional anchor up there, holding a biceps, which, like Pericles says, is often not needed. And when it's needed, it's something for the bodybuilder or for the cosmesis. then I don't want to, add additional risk of infection, of anchor, of submission to the bone in this sufficient area, and I want to go down to be out of this way, and then use the all suture anchors, which basically make life easy down there when you go supac.
I see your point, but I think, as you already said, we can just switch the type of anchors we use. I usually use PIC anchors, so I never get a cyst around these anchors. So infection, I think the risk of infection is higher with an open supac because I'm to the axilla. So I really never had an infection after an arthroscopy. And I want to win the battle, so.
Okay, Maristella, you are the winner.
Yeah.
There is one advantage of open subpectoral tenodesis. If you use the tendon, the biceps tendon as a local graft for SCR or to augment a rotator cuff repair, then you have a longer graft, because if you do a subpectoral tenodesis, you take a graft of about 9 centimeters. That is, you can use them to augment a repair or to do an SCR if you want to do an SCR with the biceps. There's a way to do it. And this was one of the reasons that I use open subpectoral. When I want to use the biceps as local graft, I prefer to do subpectoral tenodesis because I have more length. When I do it suprapectoral, the length usually is about 5 centimeters, 5 to 6 centimeters. That's one advantage. The disadvantage is that I have never experienced a failure of such a tenodesis of subpectoral, but if it fails, then you don't have tendon anymore. It's in the muscle tendon junction.
Everybody has good results.
Any questions, Manos?
Okay, yes, Alexandros Kyriakos asked if tenotomy is another pain generator. I want your comment on this. Do you believe something like this?
I do have some patients who have, within the first 5-6 weeks, not only the cramping, but some of the patients with tenotomy as well as with subpectoral tenodesis, they have this capsulitis, anterior little pain, external rotation thing. I think it's basically due to the rotator interval, but that's sometimes a moment where I think, oh wow, perhaps this biceps had some of the function Felix said of this prohibiting anterior superior escape thing, but later on they do fine, and when they got their capsule issues good, then it's fine, and then they come out fine.
And then to revise a tenotomy due to pain. Do you remember anyone that he revised the tenotomy not for deformity but for pain? This happened to you?
No, I only had to revise it for deformity, and usually those are patients that were treated somewhere else, so you never see your own tenotomy patients back to revise them. You only see tenotomy patients from somebody else. So I think whenever you decided to do a tenotomy, maybe they don't like to come back. So I only see, so that's just a personal, aspect. I've revised a few from different surgeons. I've never revised one of my own, but that's probably because they went somewhere else if they want to revise it.
Well, usually here we're in private practice and the patients are coming back to you and say, why I have still pain? And you have to solve the problem. The reality is that I have revised 1 or 2 patients after a tenotomy for pain, and also some patients for intra-articular tenodesis and the entry of the groove. But there are very few patients that they had to revise to do a suprapectoral or subpectoral tenodesis. There are some still.
And what do you prefer? What do you prefer in case of revision? Sorry, please.
I do a tenodesis lower at the either suprapectoral or subpectoral, usually subpectoral tenodesis. The very interesting thing that all the times that I did this, the biceps was stable. The tenodesis was not a failure. The biceps was fixed to the groove, and still it was painful. And this is something that I can understand, because I have the Burkhardt does the tenodesis with the interference screw. It says that he had no problems, and he does it in the entry of the groove. I think that to put there a hole of 7 millimeters is too much for the tendon, and I have never done it. But he says that he had no pain, and I think that he had pain because of the strength of the fixation. But I can understand that I can explain why some patients, I had to revise patients, and when I went there to the groove, I found that the biceps was well fixed to the bone. It was not that it was moving, it was fixed.
Can I add something to that?
Yeah.
We published a paper, 8 years ago, looking at with ultrasound in tenotomies, and we saw that even in cases of Popeye sign, there was spontaneous tenodesis. So probably in the first 6 weeks, we had some slight movement of the biceps tendon in the groove, so which is a pain generator. But after 6 weeks, we have tenodesis, even in tenotomies, spontaneous automatic tenodesis, and then the scar tissue over there, and there is no pain after that. We never had any pain after that.
Yeah.
So what Knut said in the beginning, they might have some vague pain, dull ache, but at the end, after 6 weeks, or even sometimes even more, 8 weeks, they get rid of the pain.
Most of the patients for the first 2 months are painful in the site of the tenodesis, but I'm not talking about this, because this patient that I had to revise were patients that they came 6 months, 8 months after the operation, and they had a lot of pain in order to revise them. Otherwise, I would not do this. And I can explain it, but it happened, at least in my practice, sometimes. So when the groove now is very painful, when the biceps is very degenerative, I prefer to do a suprapectoral, an arthroscopic suprapectoral tenodesis to go lower from the groove, and do the tenodesis there. I think I have the impression now that if we have a strong fixation, then we have less pain, at least in the initial phase of the rehabilitation.
Manos, just a question. So when you say strong fixation and rehabilitation, what are your tenodesis are allowed to actively move and actively contract their biceps? So how long do you keep them, calm?
Well, to all the repairs, except if I have a very bad issue, I allow the patient to use the arm from the first 2 weeks after the operation. But I say to them not to do it not to raise weights or do any abrupt movement. And so I allow the patients to use the arm, but to do them very slowly, very calm, not to do anything that is stressful to the bicep. I mean, stressful supination, to unscrew or to turn the keys to the door. I don't allow these things, but I allow them to use the arm. So And I have the impression that if we could keep the patient immobile, it's more painful, at least initially, than if we allow them to have some movement to the limit of pain. That is my way that I go with the rehabilitation, not the patients.
Felix, do you do something else?
Not really, but I mean, when I do a tenotomy, I let them go right away. I'm not, they're not limited to anything, and I don't see, problems with that. But the biceps is not even fixed, so I don't know what to do. I was told that I learned, when you fix the biceps, you gotta wait 6 weeks and let it heal, and afterwards they can, start again. And I had some failures. I had a couple, or maybe even more, where I had exactly, but the suture ruptured right on that edge of the bone where there's a hole. So I had a couple material failures, probably due to too much motion. So I do think there is a lot of force that's actually generated by the biceps that reaches the fixation point, especially when you go subpectoral, because there's no other structure that takes up the force. I do think it's a little different when you go suprapectoral, because you still have, you may still have the transverse ligament that helps to protect your repair. But I think as soon as you go subpectoral, it's the first point of fixation is your anchor or your suture, and I don't think there's much to change.
Yes, Knut.
I do the same thing as Manos does. I also tell the patients they can move when they feel comfortable, but they should not do forced motion with more than 4 kilos for these 5 to 6 weeks. But I switched to do this with my tenotomy patients as well, because I think because of the thing Pericles said, because this tendon within the groove, I believe, needs a little bit of rest to get scar tissue. There's only one exception: if one guy really wants to go back to work, has no time, self-employing and all this stuff, he can go right away. But I talk about him that it takes the time a little bit longer. He will have a little bit of this groove pain a little bit longer. So in my experience, they can move comfortable, basically everything they want, but they should not lift weight and should not do heavy work with this arm for 5 to 6 weeks.
Yeah, so I can only say it for, I do a lot of trauma patients right now with proximal humerus fractures. And there's a lot of, old ladies, old guys that get biceps tenotomies right due to the trauma case. And those guys will be able, or we want them to move the arm right away, just because of, stiff after osteosynthesis. And I don't see any issues with the biceps in a traumatic case when I cut it, and I just leave it as it is. I don't do any, suturing to the short head of the biceps or any soft tissue tenotomy, and I don't see any problems in traumatic cases after osteosynthesis, after tenodesis. So I switched, and when I do a tenotomy, I'm less restrictive.
I think that's fine, but I think the difference is in the trauma case, you've basically opened up the groove, worked around there, and this tendon is kind of free somewhere, which I believe is a difference to this 60-year-old lady who has a pulley lesion, and I basically do just cutting the biceps, a tenotomy, and this tendon, like Maristella said, fixes itself in the groove. I think this might be a different thing with these patients. But at the end of the day, I mean, we've seen it with the data, whatever we do.
It depends a lot to the type of the patient that you treat, and there are different types of patients. I still believe what I learned was where I was in training. At that time, it was AO that started the internal fixation, and the motto was life is motion. And the idea was that we have to keep moving to the limit of pain. And this is for fractures, and I think the same is for tendons. Now, if you leave the patient to follow his pain, two things happen. There are many very frightened patients that they are not moving at all because they don't want to have any pain. They are afraid of pain. And these patients are proceeding very slowly. And there are the patients that they have to go back to work or back to the sports they want, and they accept to have some pain. And as time passes, the function makes the tendon stronger, the fixation stronger, because it needs to be stronger in order to be able to function. There is an equilibrium there that you must keep, but I think each patient finds this equilibrium and goes. And I had much less stiff patients, much less painful patients during the initial rehabilitation in this way. And most importantly, I can't think of myself if I have rotator cuff tear, if someone says to me, okay, now I'm going to operate you and you have to go around for 2 months with the arm like this. I say, okay, leave it as it is. I have to go back to my life, I have to drive, I have to operate, I have to do a lot of things. If you can give me a painkiller and don't have pain, leave me as it is. But if you say, okay, I'm going to operate you, you are going to use the arm, try to use it not forceful, with not force, as you can, but try to be active as much as you can. And then nature is going to follow and bring back the function. So I think the best way to go.
So that was our today's mini battle. Hopefully it's not a battle, a real battle. We have many common things to share. And before we say goodbye, we can see the results from the second poll. The question was, which was your usual location for biceps tenodesis, and 50% say suprapectoral working in the subacromial space, 33% intra-articular in the editing of the groove, and 16% open subpectoral. I think it's something that we expect.
So we have come to the end of this mini battle and to this discussion about all these thoughts and all these problems that we have in our everyday practice. Thank you all of you for sharing your views and your ideas. And I hope that we are going to have you live next May, that we are going to have the 5th Athens shoulder course, and also that we may be able to have the possibility to have some surgery and try to see how we do all this tenodesis, to see the technical part of all this situation. Thank you again.
Thank you for inviting us.
Yeah.
Well, now Knut and I will switch the coffee to beer.
We will follow, don't worry, we will follow. Thank you once again for your acceptance and for your presence. And see every one of you in the next episode in July, dedicated to a non-invasive option for shoulder surgery. I would like to remind the participants that in order to earn the CME points, you have to fill a tiny questionnaire, which will be sent you by email. You can always follow our webpage on Facebook and LinkedIn in order to stay in touch, and follow BMed, because there are many interesting webinars hosted in the forthcoming period. Thank you once again for attending us. Goodbye.
Goodbye.
Thank you so much, guys.
Thanks
It was
very
a
much.
great pleasure. Bye-bye.
Bye.
Good choice,
Bye,
Knut.
Felix.
Wine is
Bye,
always a good
Maristella.
choice.
Bye, Knut. Bye, Manos.